Great, thank you, Stuart, and thanks for everybody to taking the time to attend this meeting with us today. So the first presentation I'm going to give today is in relation to iFactor, a bit of introduction to iFactor, the science, the technology, and also the evidence that supports the use of iFactor. So when we think about bone grafts, we automatically think of iliac crest autograft, which has been the traditional gold standard for many years, but there are now many more alternative bone graft products available, more than 400 available on the market at present. And it's very easy to consider all of these products as being equivalent, but they're certainly not. There are substantial differences between them. The majority of the products on the market at the moment are simple osteoconductive scaffolds, and these products really depend upon their overall chemistry, porosity, and structure to determine how the body interacts with them and how cells actually then start producing bone. iFactor peptide enhanced bone graft is a composite bone graft which combines an osteoconductive scaffold with a bioactive peptide to form a composite bioactive bone graft. What makes iFactor unique is this combination of a bioactive peptide with a calcium phosphate scaffold to form a biomimetic bone graft. What does the I in iFactor mean? Well, the I actually stands for integrin. So we talk about integrin factor. Integrins are key signaling molecules critical to bone formation and homeostasis, and they're very important when we start considering cell interactions with the bone graft and cell-to-cell communications. So P15 represents a small amino acid segment of type 1 collagen. This is the functional domain of type 1 collagen that's responsible for cellular attachment. And this sequence is naturally occurring within type 1 collagen. We simply synthesize the amino acid sequence synthetically and then bind the peptide directly to the surface of a calcium phosphate carrier, effectively making the calcium phosphate scaffold biofunctionalized. So why use a collagen fragment? Well, type 1 collagen is extremely important when we consider cell interactions. Cells bind to collagen and use the connection to understand and interact with the environment around them. So these binding sites are very important. They also enable the cells to move throughout the environment in response to chemical and mechanical stimuli. Movement alone, a binding site along a binding site gradient is called haptotaxis, and this differs from the more random occurrence of chemotaxis, which is what we experience with or associated with BMP2. So type 1 collagen plays a significant role in cellular interactions, and someone has devoted their life's work to mapping these interactions. And this is called the collagen interactome. And you read this like you would a page on a book. So you read from left to right and then from top to bottom, and it encodes all of the known functional domains for cell interactions on the type 1 collagen molecule. One of these key areas is the cell interaction domain, and that's right in the center pretty much of the type 1 collagen molecule. And this is exactly where we find the P15 peptide sequence. So the cell interaction domain is critical for cellular functions, and it's one of the reasons why this sequence has remained unchanged, largely unchanged, over millions of years of evolution. And that really highlights the biological importance of this area in particular on the type 1 collagen molecule. And this is what that interaction domain actually looks like on the collagen molecule. Here we have a number of binding sites that are highlighted in different colors, including P15. So you can really see that there's quite a close association across all these specific binding sites packed into this interaction domain. So one thing you'll notice from this image is that the P15 is actually a little bit tucked out of the way. It's not actually bioavailable, readily bioavailable on the surface. P15 is an area of the type 1 collagen molecule that only becomes bioavailable during remodeling or during injury processes. And this is probably one of the reasons why P15 is so much more potent for cell binding compared to some of the other peptide sequences. It's really seen as an emergency binding site. So in early studies, researchers actually found that P15 was some 4,500 times more potent for cell binding compared to some other RGD peptide sequences. So we obviously harness all of this peptide power within iFactor. And iFactor is a unique mechanism of action which is based solely upon the cell's high affinity for these P15 binding sites. So once attached via the surface integrins, the cells receive chemical and mechanical stimuli which initiate the release of growth factors such as cytokines and bone morphogenic proteins, and that subsequently results in activation of the cells. Those signals will also migrate away from the cells and influence other cells in the local area, stimulating those cells to come to the site of injury and also to differentiate down the osteogenic pathway. Most importantly, the release of and the concentration of these growth factors is entirely within normal physiological limits. So we're not talking about million times physiological dose that you would normally expect to find with BMP2. This mechanism of action is actually very well understood and has been subject of numerous publications in the literature highlighting the biological impact of introducing P15 on a scaffold and the subsequent cellular responses. So the unique mechanism of action that iFactor has differs significantly compared to that with BMP2, which is another bioactive bone graft. Most importantly, the P15 peptide is bound to the surface of the graft, and that ensures the biological activity is concentrated at the surface of the scaffold, and that provides much more predictable activation of cells compared to BMP2, which is obviously available as a small molecule, but that molecule is free to diffuse away from the implantation site. And in fact, the mechanism of action actually relies upon that to entice cells, encourage cells to the area by a process of chemotaxis. So iFactor is haptotaxis, it's more controlled, it's surface bound. BMP2 relies upon chemotaxis, chemical signals to elicit its biological response. So iFactor has a mechanism of action which is based upon the cell's high affinity for P15 binding sites, and in cell culture experiments the effect of P15 is clear, with much higher numbers of cells adhering to the surface treated with P15 compared to those surfaces without. In addition to that, P15 has also been shown to positively influence the early cellular development with a rapid development of cytoplasmic extensions and the extensive active actin filament structure as well. And these are important development processes and changes within the cell, which influence early cell-to-cell interactions and also cell migration. So in terms of the cell migration, by providing specific binding sites on the surface of the calcium phosphate scaffold, P15 improves the ability for cells to migrate and populate the surface more rapidly. This is just an illustration of those cells spreading out across a surface that is charged with P15. So also relevant for today's discussion and the presentation by Mr. Grohovac, one of the additional evaluations we've conducted is to evaluate the impact of P15 on osteosarcoma cell lines. So as a component of our IDE PMA application, we included an evaluation of the impact of P15 compared to normal type 1 collagen, which is obviously abundant within the body, within 6 primary cell culture, osteosarcoma cell culture lines. And the output from these studies clearly demonstrate that the effect of P15 is simply no more, does not adversely impact upon the cell populations compared to human type 1 collagen. So there's no adverse impact on these tumor cell lines. Critical question, does all this science really translate into clinical efficacy? Well, iFactor is supported by a wealth of clinical evidence across a number of different application areas, including our pivotal ACDF study through to intra-patient control studies and also experience within orthopedics as well. And I'll just take a little bit more time just to quickly review some of the key highlights from some of these studies. So our main pivotal study was an IDE study conducted in the US and Canada involving 319 patients recruited across 24 clinical sites. It was a one-to-one randomization iFactor against autograft in single level ACDF. Primary outcomes for including efficacy was fusion, NDI, and neurological outcomes. And in terms of safety, we evaluated the number of complications. Evaluations were at 12 months, 24, and then up to 60 months. Some of the longer term outcome measures will be in publication in the coming months. In terms of the shorter term outcomes at 12 months and 24 months, iFactor was shown to be non-inferior to autograft in all of the 4 primary outcome measures, but also part of the study, we included a prospectively defined overall success measure. And this overall success measure, for a patient to be considered as having overall success, they must have successfully achieved all of the criteria in each of the 4 primary outcome measures. So it's really your ideal scenario. The patient has successfully achieved fusion, NDI success, neurological success, and not experienced any major complications. And in that regard, in terms of the overall success analysis, iFactor patients did statistically better than those treated with autograft. And that's the first time any study involving a bone graft has been able to demonstrate statistical superiority compared to autograft in overall outcome measures. So anecdotally, what we observed from the x-rays as well within the study was that iFactor also yielded faster fusion compared to autograft. But we also think that speed of fusion is one element here. We also need to consider the quality of the bone formation. The ideal bone graft material should leave nothing behind but healthy bone at the end of that regeneration process. And this is just a high resolution CT sequence from one patient treated with iFactor, single level ACDF. On the left-hand side, you can clearly see the situation immediately post-op. There's a very dense aggregation of iFactor within the cage. And then between post-op and 3 months, you already see that you've achieved a fusion. And then between 3 and 6 months, that bone continues to develop and remodel, tending towards the properties of near normal bone by 6 months. So iFactor not only giving you the quick fusion, but also restoring near normal bone properties. With the other data that we have and study data that we're able to provide for in support of iFactor, this was a 110 patient study involving iFactor in ALIF procedures. This was a study in Australia which yielded high fusion rates at 12 months and 24 months. And the outcome of the study, and these are the words of the surgeon, the study demonstrates a high fusion rate and clinical improvement comparable to the published results for ALIF using autograft or BMP, whilst avoiding the complications specific to those materials. So high level of fusion rate without the potential for the risk factors associated with BMP in particular. This is a very interesting study from Belgium involving patients treated with PLIF cages. In this situation, the patients were treated and used as their own control, so it was an intra-patient control. One cage was filled with iFactor and the adjacent cage was filled with autograft. So it was the same patient side-by-side evaluation of fusion. And at 6 months, iFactor cage yielded a much higher fusion rate compared to that of autograft, 97% compared to 59% at 6 months. And that was a statistically relevant difference. And then at 12 months, that statistical difference was maintained. Again, I-factor still very high fusion rates compared to autograft, which is gradually catching up, but still behind at 82%. It's not until 24 months post-op that the autograft group catches up with the I-factor group. So extremely compelling evidence that I-factor is yielding higher fusion rates and a higher capacity to form bone compared to autograft. So the final study here I just want to mention is our latest study, which involves fusion in a very challenging environment. This patient group was treated with non-instrumented posterolateral fusion in elderly patients. The study was conducted in Denmark, and we're just about to publish the long-term clinical outcomes from this study, but short-term at 12 months, I-factor was shown to yield a much higher fusion rate compared to the control arm. So that control arm consisted of allograft mixed with local autograft. This particular study was extremely challenging in terms of bone regeneration, not only because you have the mechanical instability, because you've got a non-instrumented fusion, but also because this is an elderly patient population in which the bone regeneration capacity is impaired. So that's just a very quick snapshot of I-factor, some of the basic science, and also leading into the evidence. All of the preclinical information and data supporting I-factor applies equally to all of our products. So I-factor putty, FlexFR, and also I-factor plus matrix. Not all of these products are may be available in your own territory. However, all of them contain the same P15 peptide technology, which underpins I-factor. Thank you, and I'll be happy to field questions at the end of the meeting.